everybody, and welcome to the Heart Failure Hour for the month of June. This is a monthly series of discussion on topics which are related to heart failure. And today I'm very excited to moderate with an esteemed crowd to talk about heart transplantation. As we all know, heart transplantation has come a long way over more than 50 years. And to me, it still remains one of the scientifically fascinating aspect of medicine that we all it still amazes me how this whole process works. So today in this studio, I have to my left Dr. Tom MacGillivray, who's the Chief of Cardiothoracic Surgery and Chief of Transplant Medicine, and he does a lot of these things even in his sleep, is what I believe. And Tom, thank you for being here. I assure you he's not sleeping while he's doing the surgery, though.
Chief of Transplant Medicine, that's a promotion, I would say.
Yeah, you are the boss. And then to my right here is Dr. Eddie Suarez. He's the Surgical Director of the Heart Transplant Program and the VAD Program. And again, he's done a lot of our transplants since the last many years. And again, thank you for being here. They're very busy. And virtually connecting today, we have Dr. Phil Chow, who's our latest addition to the surgical team, comes from the West Coast, highly recommended, well-trained, and then he hit the ground running in the ice storm this year. Thank you, Phil, for making time to be here. And Dr. Dewei Ren, he's our procurement surgeon who has done a lot of these hearts, who spends tireless hours in the middle of the night going and procuring the heart, and we'll get a little bit of a flavor of that process. And last but not the least, we have our star guest, Caitlin Amos, who is a genetic counselor currently working at Duke. And the special secret is that she's actually a recipient of a heart transplant, and she's here to ground us all into reality and correct us what it all means having a heart transplant. Caitlin, a special thanks for you for taking the time, and I know you just moved to Duke and are having, making a great career in genetic counseling and cardiomyopathy, and I hope to get great perspective at the end as we discuss. And Laurie Loza, who is our administrative director for the heart and lung transplant program, hopefully will be joining us soon virtually. I think she got held up with some activities. So today what we'll do is spend a little time on just talking an overview of where heart transplantation lies, and then we'll watch some videos which really go into the nitty-gritty of the back end of what happens, because my first experience as a resident of transplant essentially felt like it was a James Bond movie, and I wish I could have been a surgeon, but I couldn't. So definitely I think those are some snippets which whoever is watching will enjoy. And I want to remind all of you to kindly send in your messages and comments or questions, and you can do that on the web by going to pollev.com and enter DeBakey, or you can text DeBakey to 37607. Just text in your message. You have that information on the screen. So with no further ado, we will move on to just a few brief comments on a presentation that I have talking about heart transplantation and where we stand. So we all know the first heart transplant happened December 3rd, 1967. Some of these pioneers that you see, Dr. Christian Bernard was a surgeon who did the transplant, the first transplant in South Africa. Louis Washansky essentially was the first patient who got the transplant. And then Dr. Hamilton Nacke was one of the key contributors whose efforts were not recognized until many years later. And this was in the era of racial differences that we had. So he's come to light as one of the key surgeons who contributed to this. And we celebrated the 50th year of heart transplantation recently in 2017, and there was a lot of discussion on how far we've come and how much of a reality it's become for individuals who need a replacement of the heart. While all of us dealing with heart failure have made constant effort to avoid an individual needing a transplant, which means we want people to not go into heart failure at the end. Unfortunately, it is a reality that some individuals end up needing it, and there's a constant effort with these pioneers that they've done. In the country currently, we're doing more than 3,000 transplants overall, which has been an increase over the period of last decade. 10 years ago, we were talking about how transplant volumes have not increased. I think there's been a little bit of an increase. A part of it is donor awareness, and a part of it is, unfortunately, the opioid epidemic, which has led to more donors and more drug overdose deaths. But as an entity across the country, for the magnitude of people who need it, it's still a small number, and we all recognize it. This is a slide which actually shows a comparison of 2019 to 2020, even with the pandemic and with the impact that the healthcare system has seen. Overall transplant volume had actually increased, and the region 4 is where we in Houston belong to, and we've been about the same extent of transplants overall, if any increased a little bit. So across the country, the services that were needed, many individuals, transplant teams worked hard through the pandemic, and I'm sure our surgeons here and our procurement teams can share their stories of how we overcame the travel and how we were able to achieve what we had to do for individuals who need it. We in Houston, in Houston Methodist, in the last year, we've done 56 heart transplants, which is a good size program for us, and we're very fortunate for the hard work of everybody here and also many individuals across the hospital system. And you know, it's not just the numbers, but making sure people live appropriately, because there's a lot of effort that goes into maintaining an individual after a heart transplant. And this is a graph that shows the red line is what is, the green line is actually the national survival at the end of the year, and year over year you'll see that it's somewhere in the realm of about 92-93%, which is much better than compared to an individual who needs a transplant. If somebody needs a transplant and then called end-stage heart failure, their 1 year survival is probably less than 20%, so that's a huge survival advantage. But we're also proud to have efforts at our institution where our observed survival is much higher than what is even expected, and that takes a huge army of team effort and administrative investment for us to maintain that. Of note, transplantation of a single organ has been an entity that has been prevailed, but multi-organ transplant, because as individual other organs get impacted, is something that's also grown over a period of time. You notice this graph that heart, liver, and heart kidneys have grown from the early 2000s to 2017. But interestingly, if you look at the numbers still, the number of heart livers that you see in the yellow bar is still in the range of about 25, 30, at least in 2017. And the number of heart kidneys has been much more. And this is an area which we have the proud association through the Transplant Center, where we're able to collaborate with abdominal organs, and you know, we've been lucky to be a center where we have done quite a few multi-organ transplants. So we've been the 5th in the country to do multi-organ transplants, and then 3rd for heart kidney, and really 2nd for heart liver. And we again appreciate and kudos to the kidney surgeons, the liver surgeons who help us out in this together. So to kind of briefly wrap up, it takes an army to run this, and this is the people, the physicians behind what we do, and then there's a list of nurse practitioners, support systems, administration, the nursing staff across the hospital. Everybody provides a great contribution for us to be able to get to a point of doing the transplant and also then maintaining after. So with that, I'll wrap up the first section of just talking about transplant and just some of the data, and then I want to see if any of you have any comments before we transition to the video which goes into the logistics.
No, I mean, it is really incredible how much progress has been made in the last 50 some odd years regarding heart transplantation. I mean, it's gone from being something that is surreal to real, and it makes a real difference in so many people's lives. But I hope that in the time we have left, you'll see that it doesn't just happen. There is so much preparation and work that goes into every single transplant, and we hope to provide you a window into that experience today.
No, absolutely. Eddie, what
I completely agree. Obviously, to go from where it was such a difficult and treacherous and brave surgery to perform on patients to something that's become almost routine, it's amazing that journey that's progressed in these last few years. And for me, what I've always loved since I was, 30 years ago when I was a young boy or man trying to determine what I want to do, the fascination I had with this whole process, it's still with me today. It's one of the most sacred and beautiful things I feel like that we're allowed to participate in medicine, and it's an honor to be able to participate in the lives of these patients who have received heart transplants, such as our esteemed guest here. So thank you very much for letting us be part of your life. I appreciate it.
Literally living proof.
Well, thank you. And I think, as Tom said, what you'll watch in the next many minutes is the enormous effort and complexity that goes into procuring an organ, getting it to where it needs to be safely, and then doing the surgery. So maybe before we get into the video, we have Laurie Loza, our administrative director, who got on who's able to log on. Laurie, do you want to make a few comments on the amount of effort that goes into just executing the procurement of the organ?
Sure. I think it is quite a feat to get everybody involved and kind of up to date. So when we get an organ offer, from the time that we get the initial offer to the time that we are actually in the OR with our surgeons and team transplanting, it's probably on average about 150 phone calls and text messages and emails and sort of communication points to make that, to put it all together really. And that's only if things are uncomplicated, because there are many times when there are other complicating factors, such as having multiple transplants going on, or maybe this particular recipient needs dual organs. And then we have external factors like weather and the amount of, or number of available planes and ambulances. And there's just a lot of different things that can affect, kind of getting it all to come together at the end. So we have a team of 14 people who do nothing but their entire job is coordinating transplant events. We have 6 people on call every day to manage all organ programs. And with that, we have half of that team is taking organ offers. The other half is designated to transport with Dr. Ren and our recovery team to go pick up the organs and things like that.
No, that's great. Thank you for that. And I think before we get into the video, we'll walk through the steps for the audience. Essentially, when an organ becomes available, there are organ procurement organizations under the UNOS oversight who locally do the groundwork of getting the consent and then making sure the donor is appropriately managed, and we get a call to once the system matches according to the current listing criteria. So the video you'll see is after the back-end discussions and evaluation and matching that happens among us as cardiologists, our surgeons, who we know the individual who needs it, and once that matching happens and we agree that it is a good match, then it's accepted, after which the process of procurement starts. So we'll move on to the video.
So we that's after the big, we've made a big leap from the incredible evaluation process that takes place for each person, each patient who is going to be listed for a transplant. I mean, the amount of effort and evaluation that goes in a multidisciplinary way to make sure somebody is appropriate for heart transplant. I guess that's a topic for a different day.
No, but I think I'm glad you brought it up, Tom, because that's very important for people who are watching this to understand that this decision of somebody needing a heart transplant is as big a decision for us as it should be for an individual. So the first thing we do when a patient or a person with heart failure is sent to us by their doctors thinking that you need a heart transplant, the first thing we do is essentially go back and relook at everything, that there's nothing being missed, that we can salvage your own heart and make sure you do okay and avoid a transplant. And also, apart from that, we have to make sure the rest of the body is good to accept the transplant and survive and do well. And then, of course, the last but not the least important is to make sure that the individual, their families, they're all prepared to move forward with this incredible journey. Because as Tom mentioned earlier, and as you will see Caitlin attest to, in my mind, the real heroes are people who go through this, and it's not an easy task as much as we're executing it. So I'm glad you brought that up, because it takes an enormous effort before we even reach to the point of getting somebody on the list. So we'll move forward with the process. The video that you see will last about close to 7 minutes, which is the journey that goes through the individuals going and getting the heart, and these are some raw footages, and we kind of kept it real. So we'll go ahead and play the video for you to watch.
So right now the donor OR has been set. So it's set for 2 o'clock. So we've timed everything out. Obviously we're going to the airport, lights and sirens, and shortly we're going to get on this jet and we're going to go get this organ. What we're doing right now, he's calling our coordinator that's at the bedside right now. So we want to let them know exactly when we're taking off. She'll let the OPO coordinator know where we're going, and they'll have transportation already set up for us. It's a delicate dance. Everything is timed so that we work together and that they can prep the patient before we get back. Because the perfect scenario is the cold ischemic time, which is the time from when the blood flow stops in the donor to when it's reperfused and anastomosed in the recipient, that time is short as possible. The shorter the time, the better the outcomes. I tell you, man, I've been this is like my 17th, 18th.
Yes, so I think that's Maurice, one of our donor coordinators, and you know the journey where they're essentially landing at the donor OR city.
And we can and will go as far as it's safely possible to get a heart.
People do ask how far we go to get the hearts. It's limited by the time. Like Maurice mentioned, we want to make the time between the heart stopping and being connected to another human body and getting blood as short as possible. So usually we like that being under 4 hours. or so, if possible. So that limits us in Houston to around a 1,000-mile radius, more or less.
Yeah, and I think Maurice clearly said it's a delicate dance to manage everything. And what you notice is they're landed there and they're entering the hospital where the donor is, where the team over there has made all the arrangements for our surgeons to go there and take care of the surgery, harvest the heart, and take it out. So it's an act where it's not just our teams, but they have to coordinate with the local teams, where multiple surgical teams from across other hospitals are also coming together, because it's not just the heart that's being donated, but there are other organs that are also being donated.
And it looks like at this point that we didn't see much in the operating room, but they've procured the organ in the operating room, which in itself will take a several-hour process. Once that's done, now it's a rush to get back to the recipient hospital. They've taken the ambulance, again, lights and sirens emergently, get back on the airplane and fly back to where we are.
And depending upon the distance, there's a dance that's choreographed surgically, because we want to be ready in the operating room so that as soon as the new heart's coming through the door of the operating room, we want to be taking the old heart out of the recipient, again, to try to limit the amount of ischemic time to as short as possible.
Yeah, and what you notice there is currently most of the hearts are essentially preserved in what we called as hypothermic or cold preservation method. The new era which is being worked out is a different system of a perfusion system. But what you see over here, that the heart is being transported in essentially an ice box, but preserved in a sterile solution that our surgeons prep after harvesting the heart.
And that new method, if it is able to be rolled out universally, will change transplantation, certainly heart transplantation, because quite frankly, if you live in a metropolitan area like Houston or New York City or Los Angeles, as opposed to Wyoming or somewhere more remote in the United States, your access is limited just because of time and distance.
Yeah, and I think that's the key currently. One of the biggest limitations of the cold storage system is that the ischemic time that we were talking about, the distance that comes with the fact that in cold storage we can go only so far because it is not physiological and it's out of the body. So essentially, that's the summary, and essentially what you see up here is the team has come back to the OR in our hospital, flown out, harvested the heart, come back, and then this goes to our OR where our recipient is ready to go, appropriately timed. So that kind of brings to the end of the process of what happens in procuring a heart. And I'd like to pause for a little bit and see if Dr. Ren, who's our main procurement surgeon who's done this for many years, has any comments on the whole process. And Dewey, one of my questions is, I was very excited to go on donor run, and even now I'm excited to go because I don't do it daily. Are you still excited doing it? I don't know how many times. I don't know if you have even a tab of how many procurements you've done, but I want to hear your thoughts on just you're very experienced in this for many years.
Yeah, thank you for your comments. Yeah, I did this one is almost 10 years. Okay, I'm still have a passion to do that. And for the heart transplant, is the most important is I think this first credit I have to give the cardiology and the implant surgeon. The match is very important. I just follow their, they want to take this heart, I'm going to take this heart. But the question is, evaluation is also important. And the ischemia time you just mentioned, less than 4 hours. I think this is a golden standard. And many data is already shown there. Yeah, if more than 4 hours is reduced long-term survival. So for the heart transplant, we also have to pay more attention for a lot of the risk factor. Is not only age. Age is important. So that's reason majority for our program is we take around maybe 40, under the 40 years old. So the age is also important fact for the long-term survival. And also now more donors have some issue and have the diabetes, hypertension, and also have a drug issue. So because now majority donor have some of the drug problems. So this is also evaluation for our evaluation is not only for look at this risk factor, we also have to look at anatomy and the function. So, and our program is organized very well. Since I joined here is 10 years, I see our team grow very well, is very functioning and very efficient, and also is coordinate, and they are very knowledgeable also. So we think our program will be continuous, grow have a good future.
Phil just recently joined us. He was also part of the procurement teams at other institutions and has experience as well. One question I get from other non-surgeons is when you're on site, how do you know a heart is good or not? A lot of the assessment is done beforehand when we decide whether to actually go out. But when you're in the operating room, when you do that procurement, Phil, do you have a sense of the things that you look for to say, hey, this heart is good, this heart is not good? What do you look for?
Okay.
Yes. So, when I go to procurement, examine a heart, it's very important to look at the function of the heart, to look at any external signs of trauma. A lot of the donor hearts became available because of traumatic events, car accident, or just in general trauma. So it's important to evaluate if there's any external damage. And it's important to know that when we procurement surgeons go on site to examine the heart, we already know most of the knowledge we need to know. There's usually a preoperative echocardiogram for us to look at the function, look at the valvular structures inside the heart, and oftentimes there will be cardiac angiogram for us to look at the coronary vessels. So we have a plethora of information prior to arrival, but I think, again, the most important thing is that visual inspection. Oftentimes we see incorrectable arrhythmia during examination, or coronary artery disease that was not found by pre-op studies. So those are very important things to look for. And this is really the final test before we formally accept the organ, and the clock then starts with the coordination between the donor team and the recipient team to move forward and try to preserve the heart with as little ischemic time as possible, and from the time of cross clamp of the donor heart to implantation of the recipient heart.
So I'd say that those are excellent points, and certainly for the patient who gets notified that a heart's become available, it's a very stressful time, and it's very important that we communicate and convey to the patient waiting that the goal is to get the patient better. It's not just to do the transplant. to get the patient better is going to involve getting a transplant, but we don't want to accept a heart that's not a great heart. So in a very short period of time, an incredibly extensive evaluation of that donor and of that donor's heart takes place. And this, talking to Dewey and talking to Dr. Chow, I mean, gives you a lens to look at how in-depth that evaluation really is, to make sure that the match immunologically as well as functionally is as good as it can be.
Yeah, and maybe we should pause for a second and ask Caitlin about her recollection of the day of when you got your offer, and did any of this process that you saw today, is it something that I knew about it, or did this surprise you, or what are your comments or thoughts?
Yeah, I was just recalling all of those experiences myself, and I think it's really neat to get to watch these videos and listen to you talk, because it offers details to something that, whether it was self-protective or not, I certainly didn't look into when I was inpatient. And so it's really mysterious. You know, there's a lot of things and a lot of different players and a lot of details having to fall into place and occur in the background, but you are confined to a room and, you know, potentially have a window through the internet or your family or your friends, and that's about it, and you just wait. And so I think it's really important and really a huge gift to get to think about all these different pieces that are going on in the background before you get a phone call. And I think in my own experience, I had a dry run, or I had a call and an offer and sort of a 10-hour preparation before Dr. Trachtenberg came in and said that the heart wasn't perfect, like Dr. MacGillivray was saying. Like it wasn't what they wanted to offer me. And I can at least emotionally remember just sort of the sinking feeling of that, both for myself, but also for the magnitude of people involved that I didn't even know, I think, in detail. And so I think you're limited in what you can see, and somehow in a beyond yourself way, you know there's a lot going on behind the scenes, and it all kind of climaxes when you get a phone call, or maybe two. I don't know if that answers your question.
No, absolutely. I think you know, these are forums where we're always very intrigued to hear your perspective, because you're absolutely right. This whole back end things are not talked about, and part of it is when you're in that situation, we probably don't want you to worry about all these logistics that go into it. But thank you for those comments.
But we do. But as Caitlin said, that sometimes, even though before the donor team takes off, we think the heart's good, sometimes we turn the heart down. And we have, as Caitlin referred to it, as a dry run. And as demoralizing and disappointing as that may be for the patient waiting for a heart, it really is the right thing to do.
And I think no, go ahead, Caitlin.
Oh, I was just going to say, I just to kind of underscore that, I think in my experience that there was so much emotion, again, between my own experience and my family's, and then perceiving the medical team's part in this, that ramped up and then was let down, that I think in some ways it instills a deeper sense of confidence and readiness when that next call comes, because you know that heart is for you, and in some ways you've sort of prepped emotionally and logistically for that next step.
No, thank you, and I think that answers one of the questions that come in through the audience on how often this happens. I think I would say it's probably once a year that we run into this. More often than not, most of the testing pans out. Would you agree, Tom? Eddie?
Yeah, we're lucky that most hearts we can assess beforehand. I'd say it's under 10% decline rate, but it does happen.
It does happen.
I think we'll move on to the next video, which actually showcases the transplant itself, which we are going to pick off where we left the heart in the last video. and Dr. MacGillivray will kind of walk through us for that video. And just for the viewers, it's a surgery with some bloodiness in it, so if you are not used to it, then please close your eyes. But we'll move on to the surgical part of it, Tom.
So thanks, Arvind. And you know, obviously a heart transplant is a surgical operation, but I would say it's more than that. I've been doing surgery for some time now, and a heart transplant, in my opinion, besides just being a surgical operation, it is a magical and transformational experience, certainly for the patient who receives the heart. But I also would say for those of us who are fortunate enough to participate in the operation, I mean, it's still very exciting and very gratifying to be part of it. So, but we're going to go through about a 10-minute video that shows Dr. Suarez performing a heart transplant. Let's see, good here. So you know, as we're communicating with the donor recovery team, we're trying to again orchestrate the transplant so that as soon as the new heart's coming through the door of the operating room, we're actually taking the heart out of the recipient, the old heart, and depending upon where the heart's coming from, if it's coming from a distance, it makes it a little easier. If it's coming from down the hall or down the street, it's a little bit more of a challenge, ironic, because it's in some ways easier and better if it's coming from down the street or down the hall.
I think while we're pulling up the video, maybe one of the aspects we can answer one of the questions that Eddie is coming up in. How important is it to assess the aorta of the recipient in atherosclerosis and size matching before the heart transplantation?
So the nice thing about the size question is that a lot of times we're taking out a good portion of the aorta itself and replacing it with a new fresh aorta that's by our assessment normal in size. So we can do a lot of repair of larger aortas just by using the recipient, the donor's own aorta. And in terms of atherosclerosis, which means how scarred, how much calcium, how much kind of rock is inside the aorta, that can be something that precludes some people from having a transplant. So it's something we'll look at it intensely. If someone has so much calcium, so much kind of little rocks of bone inside their aorta, that if I have to clamp the aorta and possibly break off those rocks and cause massive stroke, that can be a contraindication. So it is vital to assess it beforehand.
But that's part of the evaluation that takes place before somebody even gets listed for a transplant. So I guess we can start the video. I think we're rolling. This is the so this is the incision that we make through the middle of the breastbone, the sternum, going down through the skin and what we call the soft tissue. This is a saw. This is the for the uninitiated. This is the butane part of it, and then we have to see what we're doing, and so we put in a special instrument called a retractor that allows us to spread the chest bone apart. And Dr. Suarez is a very fast surgeon, but he's not this fast. This is etc. And this, getting the heart mobilized, this is the aorta and the pulmonary artery being mobilized so that each individual major blood vessel gets exposed and mobilized. Now mobilizing the superior vena cava, which is where the blood returns from the upper part of the body, and then going to start to mobilize the inferior vena cava, where all the blood comes from the lower part of the body back to the right side of the heart. In order to do the operation, we have to use the heart-lung machine. And that is an incredible instrument that allows us to keep the recipient safe while we're doing the heart transplant. It allows us to take somebody's heart out and sew a new heart in while oxygenated blood is being delivered to the rest of the body. And it's kind of like going swimming deep underwater with a scuba tank. It keeps you safe. You have to know how to use it, just like a scuba tank. So these are different tubes that we put in. Up above by that red tube, that's the where the arterial cannula is. And then we put a separate cannula in the supravena cava, and then one down in the inferior vena cava. So that allows us to take all the blood returning to the heart to drain into the heart-lung machine, and then come back into the aorta from the heart-lung machine. This is the aorta being cross-clamped, and now we start to cut the heart out. This is incision through the right atrium. And you'll be able to see there's many of the patients who get heart transplants have pacemakers and defibrillators. Those are the electrical leads that are in the heart to try to optimize and the function of the old heart. Now we're cutting out the old heart, leaving all of the connections in place so we can sew them together with the new heart when it comes in. And right about now in the back table, the new heart is being unpacked from the ice. So this is again, we're still taking out the recipient's old heart. Right now, this is the heart being removed from the chest. Now you're looking into the back of the mediastinum, and up at the 2 and 3 o'clock position is the left atrium. Down through 4 o'clock through 7 o'clock is the right atrium, and around 9 to 11 o'clock is the aorta and the pulmonary artery. And so preparing all of those connections, the left atrium, from which the blood from each of the lungs drains into the left atrium. So we sew the left atrium of the new heart to the left atrial cuff of to the recipient. So up at the 12 to 2 o'clock position on the screen is the new donor heart, left atrium being sewn in. And so we're now in real time, and what Eddie is doing is very efficiently and very precisely sewing the left atrium to the left atrium. This is a very important anastomosis because the new heart sitting on top of it, you don't get a chance to look at it very easily once it's sewn in. So you have to make sure that it's every stitch is done very precisely. Once that's done, now we're sewing the right atrium to the inferior vena cava. When Dr. Ren harvested the heart, he cut across the inferior vena cava where it comes into the right atrium, and that's where the stitch is going in now. And down by that tube, there's a cuff of the recipient's right atrium attached to the inferior vena cava, which is being sewn in place. And this is the connection from the lower half of the body. Now Dr. Suarez is sizing up the pulmonary artery. That's the outflow artery from the right side of the heart. Very important to cut both of those to be the right length. You don't want it to be too long, but you also don't want it to be too short. Now he's sewing the pulmonary artery to the pulmonary artery. And we use most of the anastomoses, most of the connections are sewn in with a suture material called Prolene, polypropylene. It's kind of a very expensive fishing line, if you will. And it's about the thickness of a human hair. It's very fine suture. Eventually the blood vessels will heal together, but that suture is designed to last forever. So the pulmonary artery is now sewn in place, and we won't tie that down yet because we want to be able to get the air out of the heart through that before we get the heart started. Now sizing up and trimming the aorta. That's the main artery coming from the left ventricle. Now sewing it to the recipient, the patient's own aorta, just before the aortic cross clamp. And again, using the same kind of polypropylene suture, sewing it together. Many of the patients with heart failure have part of their heart failure. Sometimes they're on blood thinners. Sometimes their heart failure causes their liver to not be working as well as it should. So we have to make sure that the sutures are put in so that it doesn't leak or bleed. Again, very quickly, but very precise work. Now, the last anastomosis is the superior vena cava, being sewn to the superior vena cava of the patient. And usually the amount of time it takes to sew a heart in probably takes us about an hour. Maybe a little less, maybe a little bit more, depending upon if somebody's had previous surgery or somebody has congenital heart disease where their anatomy is a little bit more unusual. It may take us a little bit longer. More and more, we're operating on people who have LVADs and have had previous surgery. So now we're about to de-air the heart, meaning we're going to let blood flow back into the right side of the heart and allow the blood to come out of the connection, the anastomosis, because we don't want any air to be left in the heart. That can interfere with blood flow on the right side. And on the left side, air getting to into the coronary arteries or up into the brain can cause the heart or the brain to get sick temporarily, or sometimes longer than that. Now tying down that anastomosis. Again, an extra precaution to get the air out. Now the clamp is about to come off. So now the blood flow from the patient, with the help of the heart-lung machine, is coming back, and we call reperfusing the heart, getting blood flow to the heart. And oftentimes, most of the time, that's enough to have the heart start to beat as it is there. Dr. Suarez is sewing in some temporary pacemaker wires. Sometimes the conduction system takes a little while that's the electrical system of the heart, takes a little time to wake up. And we can use these temporary pacemaker wires to not only help the heart beat, but to turn up the heart rate to work faster and have the heart work better. So as you can see, it's a very elegant operation. I think the most elegant of operations, and more importantly, it's giving somebody the gift of life. It truly is taking life from one person and giving it to another. What do you think, Eddie?
It's a beautiful narration, and thank you very much for expressing that. It's one of the things, just listening to you, I'm still in awe that we get to do this, and I see that, and there are times I have an out-of-body experience that I can't believe that we're here and doing this, and I'm very thankful to have the opportunity to participate in such a major part of someone's life and a turning point. So yeah, it's again my favorite operation I think to perform.
I would say that over the years, when you're talking to a patient who has heart failure, and you bring up the idea of having a heart transplant, and Caitlin, I really want you, if you can, to talk about this. It's such a crazy idea to some people that why would you have some experimental operation that will keep me alive but won't allow me to do the things that I like to do. And if you come away with nothing else from this hour watching, I hope through Caitlin you can see that not only does a heart transplant keep you alive, it allows you to live. It allows you to do the things that you need to do, that you want to do, and everything that you can do. But don't take it from me. Let's talk to Caitlin about that.
Absolutely. I think we have a lot of questions, but I will go over time. But I want Caitlin to kind of talk to us about, really, we've seen the journey of a heart being brought in and the heart being implanted and then sewn in, and then the real journey starts. And Caitlin, we want to hear you about your process of recovery and how you have done and how you're doing, because I'm sure when anybody looks at you, they'll be shocked to hear that you have a heart transplant. So share with us your journey until now since the transplant.
Yeah, thank you, and thanks for letting me share. It's I think a huge gift to get to tell my story and think out loud about my story, but I think even more special and meaningful and a little bit overwhelming to get to do that with people who have literally saved my life and put a heart in me. So I'm sitting with that right now. I can tell a little bit of my the sort of chronological journey since transplant, and then I've sort of listed off some thoughts about my takeaways of life after transplant. But the situational journey is that I was transplanted in the middle of grad school, 2 months in, so fall 2018, and spent a good amount of that next year, but especially that first 6 months with the kind of 1 step forward, 2 steps back healing process that I think a lot of recipients will be familiar with. And I can, if people have questions, I can certainly go into more detail about what led up to transplant and what in detail came after. But I think one of my biggest thoughts that I wanted to share is really coherent with what Dr. MacGillivray was saying, and that's just that when I think about life after transplant, I just want to start by saying there is life after transplant. And that wasn't always something that I allowed myself to imagine. I think that, again, coherently with what Dr. MacGillivray said, I realized really belatedly that I had scripted my life up until the point of transplant. I had lived with heart failure for 12 years, and transplant was sort of as far as I let my imagination go to. And I didn't really consider it. I didn't consider life beyond it. It felt kind of impossible and scary to even grasp. I read a book recently about another woman who had her own medical journey, and in that book she had talked about the world that we live in having sort of 2 kingdoms, and one of those kingdoms being the kingdom of the sick, and one of those kingdoms being the kingdom of the well. And I think that resonated so much because I think with transplant, no matter what your backstory is that leads up to that, there's this experience of that sort of transition. With transplant, you become this citizen of the kingdom of the sick. For me, that was 12 years. Some people it's 48 hours. And you've lived in this space of constant decline and readjustment and limitations and tentativeness, this sort of downward trend. And so it takes some getting used to the fact that there's this possibility again, even the idea of possibility or upward trend. I think it's a huge adjustment. And while transplant isn't 100% a cure yet, I think you trade in so many of your old limitations for some new ones, but on the whole, it opens up so many doors to possibility. But I think the transition from one kingdom to another, as this author put it, can feel kind of hard and confusing, and it's an adjustment to learn to live in the kingdom of the well again. So I think that is resonant in some ways with what Dr. MacGillivray, I think, was trying to get at in this process. I think in that healing process, I think I've learned to be patient. There is life after transplant, and you get a heart to live, to be alive again. but you can't hurry that process of being well. It's like a really bumpy road at first, and it's not linear. Healing's never linear, I don't think, and it can take so many different shapes. The first year especially, I think, in retrospect, I would think about that first year as being like an investment in your future possibility. It's a very protective year. It's a very, I think, regulated year. You're like learning how to take all new medicines and let your body adjust to new medicines and adjust to the fact that, like this video we just saw, there's literally a new source of life inside your body. And so I think the first year is precarious, but I think in the long run, the new normals that come from that, while they look different for every recipient, can be better than life was before. I think for me, some of those new normals have looked like getting to run again. So I was an athlete growing up, and I've gotten to the point where I can run some 5Ks. I've gotten to run some 5Ks in the last few years, and I'm not, having any sort of Olympic level times, but I can keep a good pace and enjoy my body in that way. And I think some of the new normals for me, I got to finish grad school and lean back into the idea of a career that I'd been really captured by. I've enjoyed eating certain foods again that I think at the end of heart failure I was a little bit adverse to. And then I think at the same time I'm learning how to accept my own vulnerability. Again, the sort of trade-off of immune suppression, and especially in an era like COVID, you feel so strong and alive again, and have to sort of have this cognitive dissonance of being a little bit more vulnerable than even perhaps you were or lived before transplant. I think a couple other thoughts, and then I'll be done because I know we're running out of time, but I think that transplant for me, while it's mysteriously for the recipient and their life, it's also for our people. It's for my people and your people when you receive a transplant. And I think whether that's like one person and a partner, or to your entire town and community, or all the nurses on your floor, I think, your people go through the transplant with you, and they go through the fear of it and the exhaustion of it and the hope of it and the gratitude of it. And so I think it's hard when you're in survival mode, but I've learned that it's important to let these people be part of it, because you really deeply need them. You can't go through such a intense process without them. And then I think on a more meta level, but I think it also comes back to a really practical place, is that just accepting this gift of life, accepting someone's heart, like my donor's heart. It's like one of the hardest and the most important processes on the other side of transplant. And it's not automatic. It's not a given. I think transplant recipients suffer a lot, and they go through a lot of trauma, and then you're tagged with wrestling and grappling with this indebtedness to someone else's life and the loss of someone else's life to give you life. And I think there's a huge psychological burden with that. But I think it's also this really beautiful embodied process when you kind of put mind, emotion, and even the physical, like within the first year, you're physically having to adjust to accepting a heart. And I think that the sort of comprehensive process of that, until you can call it your own, you can receive this gift and call it your own, is one of the most important and hardest things about living with a transplant. So yeah, I think that my maybe the theme of everything I'm telling you is that transplant recipients have this incredible juxtaposition between sort of wonder and grief, that you live with this amazement, the science we've been learning about, and also there's been a lot lost to gain that life, and I think that you sort of carry that tension in your body, and it shapes the way you see the world.
Caitlin, I think you have very beautifully summarized aspects that we all wonder and really commend all transplant recipients who really struggle with that battle. And I think I don't have words to describe. I don't think we talk enough about it with our recipients, and one of our efforts has been to kind of create a support system for that, because you know the best, and I'm happy to see that you have balanced that, and then being a key support. And we've had some conversations on you helping out, kind of spearhead our support group. So again, thank you for doing what you're doing, and then thank you for kind of being here today to share this with people who are watching. I do have to say that you have a friend who's watching, some CTICU nurse. He's a friend of yours. She knows you're on live, so she's thanking in general us, but I think she probably wants to thank you for being a hero for this.
I too, Caitlin, it's so wonderful to see you. I have to say that whenever I see you, it's a moving experience. And that, that to be able to see you doing so well, and having seen you when you were not doing that well before your transplant. One of the things that comes up that we haven't talked much about is the donor experience. The people who are willing to give this incredible gift to someone else. And it almost always is in the midst of a terrible tragedy. And you ask a family the unaskable at the worst time of their lives. And people are so generous and so thoughtful and so kind to do it. And I oftentimes hear from patients that receive a transplant or families, there's some level of uneasiness or discomfort about what it means for the donor family. And in my experience in talking with many donor families is that it turns tragedy into something beautiful. It allows their own family members' tragedy, their death, to become somebody else's life. And to see people like you doing so well, it sustains families of donors. So thank you very much for living so well.
Yeah, thank you for giving me that opportunity.
No, that's great, Caitlin. I think we are over time, but I think it's okay because this is live and we can spend more time. This is very relevant. Maybe there's one question that came through which maybe you could reflect on or comment on. I think some of the comments of recipients are they're worried about the side effects of the immunosuppressants. I think the question that was framed was more of a toxicity of these drugs, and I think there's a spectrum of toxicities that happen, but instead of calling it toxic, I think those are effects that you have to get used to some. So how have you coped with that, or have you adjusted, or was there an adjustment period, or was it smooth sailing for you?
Yeah, I think that it's always an adjustment, and I think that's a huge part of, again, sort of the trade-off of transplant. In some ways, like, again, I had lived with heart failure for 12 years, and so I kind of took all my medicines and bottles and got rid of them, and then inherited quite a few more. But yeah, I think any time that you're taking on like daily regimen of very chemically intense drugs, it's a huge transition process, and especially as your body and your team are helping you again modify those to work as best as they can for you. And so I certainly had hard adjustment moments of some GI things, and I lost a lot of hair. My first, one of the immunosuppressants I took, I lost a lot of hair, which for a female is hard, and it's sort of like, in some ways, just the tip, it tips you over because you've gone through all this other things, and I remember calling my transplant coordinator and being like, I'm losing hair, like I have to stop this immunosuppressant because I just can't handle this anymore. And then I had more significant things. I had like kidney and renal function that was affected by those drugs, and swelling from steroids. And so yeah, there's a lot that your body adjusts to, and also I think you learn to stay the course, and the body is amazing in that way, that over time and with sort of the expertise of your team, you adjust. And I think that at this point, it's not something I think about anymore. I just take them, and the side effects aren't a part of my life or anything I even notice.
No, thank you for those comments, and I think that's important to know that there's a group of people, the coordinators or nurses, who, for the lack of better terms, I tell my patients that you're going to inherit a grandmother who's going to chase you to make sure you do the right thing. They're always available, and I think end of the day, it's a discussion and negotiation to an extent to minimize all these side effects. And then as your living example, I think you're back to a almost normal life with medications, but hopefully you'll compete for the Transplant Olympics. That hope, I think, might resume after this pandemic stuff.
Yeah.
There are a lot of questions that have come in. We'll answer a few. I think one of the maybe we can ask Phil to comment on. The question is about advances in medicine and transplant and the heart in the box that is still beating until it's transplanted, and that's the OCS system. And I think Phil, I think if you had exposure, that's your area of interest, so you can tell the audience on where we stand with it and what the concept is.
Yes, I'm happy to answer that. So like my colleague Dr. MacGillivray mentioned earlier, this is going to be a breakthrough, and it's going to be a groundbreaking device where we can, as previously mentioned, the ischemic time, where is the time that the donor heart is out of the body in cold storage, is a major determinant of the outcomes after heart transplantation. So with this heart in a box device that's being evaluated for FDA approval right now, eliminates the ischemic time concerns, because we can go, in theoretically, very long distance to procure the heart and preserve the heart on their patented system. And while the heart is beating in a box, being transported theoretically across the country, there are medications, there are parameters that we monitor on the box, where we can optimize the heart function and sometimes restore the heart function when it was initially perhaps not optimal. And by the time the heart in the box arrives to the recipient hospital, oftentimes we can determine if this is based on the parameters, the lab values on this donor heart in a box. We can decide if it's in fact a good heart to implant, or we reject at that time. So I think our center is definitely looking into this device, and is very interested in investing in this endeavor. It's going to open up plenty of opportunities, and most importantly, benefit our patients and improve the patient outcome down the road.
Thank you, Phil. I think as Phil mentioned, it's really the next breakthrough that we're looking into, and it's being studied, trialed, and centers are using it in the kind of the research atmosphere for the heart. That perfusion system has been used in other organs previously, so we're excited to kind of get there, and hopefully the FDA approval and those things will move on, and then the applications will expand beyond what's being studied. So I think we've spent a good hour and 10 minutes, and there are a lot of questions. I apologize for the audience to not being able to get to, but feel free to send in an email if you have questions that we can answer. My email is bhimaraj@houstonmethodist.org, which was on the slide, so feel free to send the questions and we can answer them. But I want to thank all of our panelists and to be here, and both of our surgeons who have walked through the surgery. And any last minute comments, Dewey or Laurie or Caitlin, you want to have some closing remarks?
I don't think so. Just grateful to be here with you guys.
All right. Thank you. Thank you, everybody. And please watch out for the next Heart Failure Hour coming up next month. Again, as I mentioned, this is every month that we'll address various topics, and I'm very excited that we covered various aspects of heart transplant today. Thank you and have a good evening.